Hello, everyone. So today I shall be discussing about very important talk scenarios. That is acute coronary syndrome, and this was published in 2023, and myocardial infarction in pregnancy. This was published in 2013. So I have summarized both the talks, and this is also a very important topic from examination point of view. So let's start our discussion. Acute coronary syndrome. It may occur at any gestation and also postnatally, and it is more common in the third trimester. And it is 3 to 4 times more common in pregnant women than age-matched non-pregnant women. What about the main causes of acute MI in pregnancy? So atherosclerosis has now overtaken PASCADE, that is pregnancy-associated coronary dissection, as the most prevalent etiology. And this is probably because of the rising maternal age and comorbid risk factors. So let's see what are the main causes. So one is coronary atherosclerosis. Then there are non-atherosclerotic causes. These are less common: coronary artery dissection, coronary artery thrombosis, spasm of coronary artery, and this can be spontaneous or drug-induced, like if the patient is on terbutaline, ergotamine, bromocriptine, and cocaine use, so there is risk of acute myocardial infarction in pregnancy. So when we are taking the history, we have to inquire about these medications. Always we have to ask about the use of any recreational drugs like cocaine. What about the risk factors? So risk factors for MI, these are high parity, where the woman has more than 3 children, increasing maternal age if she's more than 35 years of age, pre-existing hypertension, diabetes, ischemic heart disease. If she's a smoker, she's obese, she has a strong family history of cardiac conditions. Other risk factors are hyperlipidemia, preeclampsia, eclampsia, thrombophilia, migraine headaches, postpartum infections, and blood transfusion. Very important point is that maternal death risk was greatest if the infarct occurred in late pregnancy or if the delivery occurred within 2 weeks of infarction. That is why if a woman sustains myocardial infarction, then delivery is delayed for about 2 to 3 weeks. This allows the woman to recover. Then how is the diagnosis made? So usually the diagnosis is made by the typical history of chest pain and shortness of breath given by the patient, and she is also going to say that there is radiation of the chest pain to the arms, neck, or jaw. And important investigation is ECG. So in acute MI, you will see ECG changes. That is, there will be ST elevation, ST depression, symmetrical T wave inversion, newly developed Q waves. And we have to see the normal variations in pregnancy. We have to remember these normal variations in pregnancy, which can happen in ECG. Okay. Then how many types of acute MI are there? So there are 3 types. Acute MI is divided into 3 groups. One is the ST elevation MI. Okay, so what happens here? That ECG will show ST elevation or new left bundle branch block. Clinical features. So typically the patient will complain of chest pain, shortness of breath or ventricular arrhythmia, hemodynamic instability, and time to definitive treatment is the strongest predictor of outcome. So MI has to be managed promptly. It is an acute medical emergency. National targets focus around 1 hour window between ECG diagnosis and restoration of coronary flow. And also the cardiac biomarkers are raised. That is, mainly troponin is raised. And ECG and clinical history are sufficient for diagnosis. ST elevation MI accounts for about 75% of acute coronary syndrome. Second group is non-ST elevation MI. So as the name suggests, non-ST elevation, there is no ST elevation. There is ST depression and T wave inversion. Although ECG can be normal, typically it is a more stable clinical situation. Although there can be hemodynamic instability, cardiac biomarkers like troponin are raised. Risk assessment is very important to stratify the patients who would benefit from an emergency procedure like angioplasty against a procedure delay or conservative management. Then third group is unstable angina. So what happens here is that there is chest pain or shortness of breath at rest, sometimes with the same ECG changes as in the non-ST elevated MI. Okay, but there is no biomarker rise. That is, troponin will not be raised. Now, this has to be differentiated from stable angina, and we should remember that stable angina is not an acute coronary syndrome. In stable angina, clinical feature is same. Patient will complain of chest pain or shortness of breath, which is relieved by rest. In unstable angina, chest pain or shortness of breath is not relieved by rest. Patient will be complaining of these symptoms even at rest. That is why the name is unstable angina. Stable angina, where the patient symptoms will be relieved by rest. Again, there is no biomarker rise. That is, there is no rise in troponin, and ECG can be normal in most cases. Now, what causes ECG changes and rise in biomarkers? What happens that if there is interruption of coronary flow and it persists for many hours, then there is myocardial ischemia, and this causes cell death, and this causes ECG changes and a biomarker rise. If provisional diagnosis of acute coronary syndrome or MI has been made, but ECG and biomarker profiles are normal, and patient is still complaining of chest pain, then clinician should review the diagnosis. What about the symptoms of acute coronary syndrome or acute MI? So, as we mentioned before, typical symptoms are chest pain or epigastric pain that may radiate to the neck or arm. There are atypical symptoms like non-specific pain, nausea, vomiting, and back pain. There can also be dyspnea, hyperhidrosis, that is excessive sweating and agitation. Women are more likely than men to describe the atypical symptoms. Regarding the examination, it may be unremarkable, so we have to focus on the history. Vital signs may indicate hemodynamic instability. Patient can be having weak pulse, and history and examination alone may raise the suspicion of acute coronary syndrome or MI, but diagnosis is often delayed. Specific investigations are done because they can provide greater clarity. So let's discuss about the investigations. Important ones are ECG, chest X-ray, cardiac biomarker, that is troponin, and echocardiography. So ECG changes, as we have discussed, there can be ST elevation and reciprocal ST depression, ST depression alone, T-wave inversion, or new bundle branch block. What about chest X-ray? There is no specific signs, but there may be signs of related left ventricular failure like pulmonary edema, venous congestion, pleural effusions, and septal lines. Now, patient will be concerned about the radiation dose. So we have to counsel the patient that chest X-ray gives an estimated fetal radiation dose of less than 0.001 milligram, and this is very minimal. In fact, it is negligible. Fetal malformations can occur where the radiation dose is more than 50 milligram. Then the important cardiac biomarker which is elevated is troponin. It can be troponin I or T. Negative troponin at presentation does not exclude cardiac damage because it can take 12 hours for the level to peak. So if it is negative at the presentation, then we can repeat the troponin if there is very high index of suspicion for acute coronary syndrome. What about echocardiography? This may demonstrate regional wall motion abnormalities in a specific coronary artery. So the area which is affected, it will appear less contractile. And it can also confirm or rule out other differential diagnosis like pulmonary embolism, cardiomyopathy, but normal echo does not exclude the presence of a pulmonary embolism. What about angiography and angioplasty? Very important investigation. So for the urgent assessment, cardiac catheterization and angiography is done, this is done with a view to proceed to angioplasty, and this is the gold standard. Angiography, that is arterial access to direct imaging of the coronaries, can be achieved within 5 minutes. So it is done, it takes very less time, and it is a very important investigation. And once angiography shows that which part of the artery is involved, in that case, intervention can be done. That is, angioplasty can be done. Angiography can be performed during pregnancy with relatively very low fetal radiation exposure, that is about 0.075 milligray. But radiation to the mother is higher. Okay, but the literature says that given the clinical scenario, it is likely without relevance to decision making. So angiography can also be performed during pregnancy. Now, what about the arterial access? So it can be done through the radial artery, and radial access has further reduced the radiation to the fetus compared with the femoral access. And for coronary opacification, iodinated contrast agents are usually used, but like these do cross the placenta. Like these iodinated contrast agents, they do cross the placenta, but they are not associated with teratogenicity. What about fetal shielding while doing the procedure? So fetal shielding with a lead apron does not reduce radiation because most fetal radiation exposure occurs through scatter. What about other investigations? So cardiac computed tomography. It is an efficient non-invasive assessment. It is a very good investigation, and it helps in the assessment in the non-pregnant population, but not readily available on an emergency basis. And unlike invasive angiography, it does not provide an opportunity for instant treatment as well. Here, the radiation dose is 1 to 3 milligray. What about cardiac MRI? So there is no indication for its use in emergency setting within the pregnant population. However, it may be used in the outpatient follow-up or in patients with acute myocardial syndromes and unobstructed coronary arteries to obtain a definitive diagnosis. So in emergency setting, cardiac MRI is not used in the pregnant population. What about CTPA, that is CT pulmonary angiogram and ventilation perfusion scan? So it has again got no role in ACS, but they are important in the exclusion of pulmonary embolism. Coming to the management. It should be managed urgently because it is life-threatening to both mother and child. So the management of acute coronary syndrome or acute MI in the pregnancy will be done by the MDT, that is the multidisciplinary team, which includes senior obstetrician, anesthetist, cardiologist, pediatricians, and the woman, and also the GP should be kept informed about the progress. Healthcare facility should be well equipped and well staffed, and there should be both cardiac and obstetric intensive care. What about the procedure, that is percutaneous coronary intervention, that is the PCI? So this is internationally accepted gold standard of treatment outside the pregnancy. After diagnostic angiography, once an obstructed coronary has been identified, then attempt at revascularization can be done. What about the management in pregnancy? So the general consensus is that conservative medical management is preferred during the pregnancy. Usually no surgical intervention is done. And the management, this depends upon the hemodynamic stability, continuing symptoms and flow within the true lumen. Pregnancy is not a contraindication for PCI. So if needed, PCI, that is percutaneous coronary intervention, can be done. No woman should be denied diagnostic angiography during the pregnancy. If needed, subsequent intervention should also be done because this is a life-saving procedure. If there is hemodynamic instability, then immediate intervention is indicated. And ACS incorporates spectrum of presentations. So intervention, that is PCI, percutaneous coronary intervention, may be delayed until later in the pregnancy or even until after delivery. What does the European Society of Cardiology suggest? They suggest that if possible, PCI, that is, intervention, should be delayed until after the 4th month of pregnancy, allowing as much time as possible between organogenesis and radiation exposure. To maintain the stent after PCI, dual antiplatelet treatment is recommended for specific time periods because failure to adhere with these time periods can increase the risk of stent restenosis, which is usually catastrophic. What about drug-eluting stents? They have the same minimum dual antiplatelet treatment requirements as bare metal stents, and they are now the preferred option in pregnant women as within the non-pregnant population. What about thrombolysis? So it is still used globally, and particularly it is used where percutaneous coronary intervention procedure is not readily available. However, there is increased risk of bleeding. It is relatively contraindicated in pregnancy because of the risk of maternal bleeding, which mainly arises from the genital tract, and it can cause subplacental bleeding. In the acute phase, like in acute MI, priority must be placed upon stabilizing the woman. Rapid assessment has to be done, and there has to be liaison between the cardiology and obstetrics. Most senior team members should be available. What about the pharmacological treatment? So there are medications which are given in the acute phase, that is in the acute MI. Important ones are aspirin, heparin, antiplatelet agent, that is clobetogel, analgesics, and nitrates. If there is, like if delivery is not imminent, then treatment is done with loading dose of aspirin. 300 milligram of aspirin is given initially. Then the dose is reduced to 75 milligram once daily. Heparin is given as the therapeutic dose, and it is given subcutaneously. Heparin is typically continued until the day before angiography. If angiography is available immediately, then subcutaneous heparin is not given. IV, that is intravenous heparin, is given during the procedure. What about the clobetogel? So it is safe in pregnancy. Loading dose is 600 milligram, and after that, the dose is reduced to 75 milligram. So just remember, aspirin, the loading dose is 300 milligram, and in clobetogel, the loading dose is 600 milligram, and later on, 75 milligram is given. Use of antiplatelets can be reviewed at the time of angiography when decisions regarding stent requirements have been made. If there is chest pain, then we are going to give appropriate analgesics. Nitrates, that is glyceryl trinitrate, can be used if needed. And however, it can precipitate uterine hypoperfusion. If there is hemodynamic instability and it is refractory to successful revascularization, then inotropes or mechanical augmentation may be required. What about continuing medications for long duration? So joint decisions should be made regarding this between the obstetrician, cardiologist, and the woman once the angiography results are known. So for long duration, aspirin can be given. It is safe in pregnancy and breastfeeding. We can give clobetogel also, but we have to take care that when the woman is in labor and regional anesthesia is given, then it has to be stopped 5 to 7 days before the regional anesthesia. Then there are secondary prevention medications, beta blockers. They are safe in pregnancy. ACE inhibitors and statins, they're not safe in pregnancy, right? So regarding the beta blockers, they are considered safe, can be associated with fetal hypoglycemia and growth restriction. Bisoprolol is more cardioselective, and this is the preferred agent in ischemic heart disease. ACE inhibitors and angiotensin receptor blockers like ARNIs, that is angiotensin receptor neprilysin inhibitors, they are teratogenic and contraindicated in pregnancy. Then what about breastfeeding? Angiotensin receptor blockers and ARNIs should be avoided in breastfeeding, but ACE inhibitors can be used in breastfeeding. Furosemide, it is safe in pregnancy and breastfeeding, but it should only be used cautiously in specific circumstances. Other diuretics like thiazide and spironolactone should not be used in pregnancy, although they are thought to be safe in breastfeeding. Statins should be avoided. They are not safe. Anticoagulants. So we know low molecular weight heparin and fractionated heparin, both are safe in pregnancy and breastfeeding, but they carry risk if given around the time of delivery. That is, there will be risk of bleeding. So there has to be careful bridging plans. That is, bridging thromboprophylaxis has to be done. We have to involve the hematologist for planned delivery, like if the patient is going for elective cesarean section or induction of labor. Reversal agents, that is, antidotes, may be needed in the emergencies. What about direct oral anticoagulants? There is not enough safety data regarding them for the use in pregnancy, and they are not recommended. Warfarin is teratogenic, but it is safe in breastfeeding. Coming to delivery. In acute MI, it is delayed for 2 to 3 weeks so that the woman can recover. And we have already discussed that within 2 weeks of acute MI, there is increased risk of maternal mortality. Delivery does not need to be undertaken before intervention, that is before percutaneous coronary intervention. If the woman has history of cardiac disease, then she is recommended to deliver by 40 weeks. Mode of delivery, this will be determined by obstetric factors, so patient can have vaginal delivery as well as cesarean delivery. Induction of labor is safe, and what are the agents used in induction of labor? So prostaglandin E analogs like Prostin, Propes can be used, oxytocin can be used. However, in more severe or unstable cardiac function, prostaglandin F analogs like carboprost and ergometrin should be avoided because of the potential for vasoconstriction, and this can affect pulmonary or coronary vasculature, and this can cause right heart strain or myocardial ischemia. So remember that in severe cardiac dysfunction, prostaglandin F analogs like carboprost and ergometrin should be avoided. They cause vasoconstriction. Slow IV infusions of oxytocin can be used. In the second stage of labor, so 2 hours for passive descent of the presenting part is allowed before active pushing because this can shorten the duration of pushing. Do we use routinely instrumental delivery to shorten the active second stage? No. It is no longer routinely recommended. Okay, so assisted vaginal delivery with the help of instruments to shorten the second stage of labor is no longer routinely recommended. Okay. What if there is severe cardiopulmonary shock or cardiac arrest? So CPR is done with the left lateral tilt to relieve iotocaval compression. If gestation age is more than 24 weeks, then perimortem cesarean section should be performed. If cardiovascular output is not re-established within 4 minutes. Okay, so this is the time period. Neonatal support should be sought immediately. What about future pregnancy? So in a woman who had history of acute MI, in those women, there has to be preconception counseling and very well-planned antenatal care because there is risk of recurrence of acute coronary syndrome or MI in future pregnancy, and it is about 9%. Optimization of cardiac function is essential. Medications has to be reviewed. Teratogenic drugs should be changed to pregnancy-friendly and baby-friendly medications, and this is done by the specialist. We have to discuss about effective contraception to avoid any unplanned pregnancy, and also in those who are still optimizing their health. Very important point is that pregnancy should be delayed for at least 12 months, that is for at least 1 year after an acute coronary event, even in women without continuing ischemia or without cardiac dysfunction. So pregnancy has to be delayed for at least 1 year. That is why effective contraception has to be discussed with the woman. So what are the contraceptions? Barrier methods, not recommended because of the high failure rate. Combined hormonal contraceptives, they are UKMEC4, that is contraindicated because there is risk of VTE, MI, and bursting hypertension. What about systemic progesterone-only contraceptives? They are not contraindicated. They can be used. So we have the POPs, we have injections, we have Mirena coil as well. What about the IUDs? So copper IUCD, LNG IUS, that is Mirena, coil can be used, but they have to be inserted in the hospital setting because there is risk of vasovagal collapse because of cervical stimulation at the time of insertion. Sterilization, that is permanent method of contraception. So laparoscopy may not be possible in women with severely impaired cardiac function. Emergency contraception, yes, they can use all types of emergency contraception, that is levonorgestrel, Elavon, that is ulipristal, and copper IUCD. So this box is from the TOG, and I have just discussed about the contraceptive methods which are indicated and which are contraindicated in acute MI. Management of future pregnancy. So again, management is important, and we know these patients will always be managed by multidisciplinary team, which will include senior obstetrician, cardiologist with experience in caring for pregnant women, obstetric anesthetist, GP, specialist nurse, and also the specialist midwife. So we have to do the risk assessment to assess the disease severity. This will be done by cardiac investigations, which we have discussed, by checking the cardiac biomarkers, ECG, echocardiography, cardiac CT, and MRI. If the assessment shows that there is residual cardiac impairment, then risk stratification has to be done using the modified WHO classification. And if the woman is having class 3 or class 4 disease, then they may be advised against pregnancy. If the woman is already pregnant, then we have to discuss about termination of pregnancy. How termination of pregnancy will be done. So it can be done by both medical or surgical method. However, elective surgical termination of pregnancy carries a lower risk of failure. How about the risk assessment? So it has to be individualized, and women should be reviewed at every antenatal visits. There are modifiable risk factors like obesity, smoking, alcohol consumption, blood sugar control, blood pressure control, and these should be addressed and monitored. Medication review is very important. It is done in the preconception appointment or during the first antenatal appointment if the woman is already pregnant. If the woman is taking the medications and she's on long-term medications, which we have just discussed, they should not be stopped abruptly, and they have to be stopped or continued only after discussion with the specialist. Patients should be closely monitored throughout the pregnancy with regular multidisciplinary antenatal appointments. So it's going to be shared care in the joint clinic involving obstetrician, cardiologist, anesthetist, and in the later weeks of pregnancy, pediatrician as well. GP should always be informed about the care which is provided to the woman and also the management plan. So GP should always be there in the loop. What about repeating cardiac investigations during pregnancy? There is no clear guidance for this. Any change or deterioration in symptoms need rapid specialist assessment. So that was all about acute MI and acute coronary syndrome. And I have tried to keep it as simple as possible. I hope it was helpful. Thank you. Thanks for watching, and thanks for listening.